Good afternoon, one and all. My name is Megha and I am a senior researcher at the Center for Improving Value in Healthcare, or CIVHC. Today's presentation topic is Hospice Care in Colorado, a claim-based identification approach. This topic is a part of the larger end-of-life portfolio work. It is a small exploration done by my team and me to understand hospice care claims using the Colorado All-Payers Claims Database, or CO APCD. Before I dive into the topic, I want to talk about CIVHC briefly. We are a non-profit, independent organization. Our role is to provide partners with resources, services, and unbiased data they need to improve health care and health outcomes in Colorado and beyond. Our vision is that everyone has access to affordable, equitable, and high-quality care. That commitment to equity is central to work I am sharing today. The Colorado All-Payers Claims Database, or CO APCD, includes medical, pharmacy, and dental claims data, covering over 70% of Colorado's insured population from 2013 to 2025. It contains over 1.3 billion claims from 33 commercial insurance, Medicaid, and Medicare, and is updated monthly. Key exclusions are ERISA covered self-insured plans, TRICARE, Indian Health Services, and the uninsured. Despite these gaps, I really believe that the CO APCD is a critical resource for analyzing healthcare costs, trends, and outcomes for the insured population in Colorado. The background of this topic: the potential positive impacts of hospice care are complex and challenging to quantify. Although patients who do not receive hospice care are more likely to have costly and unwanted end-of-life care. Hospice analysis generally uses EHR, or Electronic Health Record Encounter data, or CMS hospice care population level benchmarking, which are incomplete. So our research objective was to validate a new methodology for identifying hospice care in claims by matching patient hospice care indicators on death records with healthcare claims database data in Colorado APCD, providing a descriptive population analysis, a future cost-benefit evaluation of hospice care utilization. The study design for this topic: it is a retrospective observational study done on end-of-life cohort. We linked CO APCD data with Colorado death records received from CDPHE. Cohort contained members who had died between 2018 to 2021. Claims of the last 4 years before death of such members were used. CDPHE matched CO APCD data and provided members' cause of death and if they were enrolled in hospice care at time of death. On CO APCD front, we flagged hospice care claims using place of service 34 code, CPT hospice codes ranging from T2042 to T2046, as well as bill type codes 81X and 82X. This was done along with hospice provider taxonomy codes in CO APCD. The filters used to create this cohort were inclusion criteria like members who have died in between 2018 and 2021, members with 18 years or older age, members having more than 6 months of healthcare coverage before death, and they also having 50% of healthcare coverage in last 3 years before death. Exclusion criteria were like traumatic deaths, people with claims after they had died. If they had more than one claims after they had died, we removed them. And lastly, people without 6 months of eligibility before that. We wanted to capture the healthcare needs of this population, especially end-of-life care needed for this population. So our population, the overall set was 94,475 CO APCD members. Among these, 39,000 or 20 or 42% of the total had at least one hospice claim in last 4 years before death, while 47,808 members had CDPHE flag. Moreover, not all members with CDPHE flag had hospice claim, and not all members with CAPCD hospice claim had CDPHE flag. This discrepancy was one of the reasons why we wanted to do this study. As stated before, 47,808 or 51% of cohort had hospice CDPHE flag, meaning they were in hospice care at the time of death. Many members can be in hospice care but can also have other types of claims like inpatient or facility. Unless specifically marked or billed, these claims are not flagged as hospice care on claim side. Among 47,808 members with CDPHE flag, only 27,664 had a hospice claim in our data, a match rate of 58%. This is considerably a high match. We then looked at the payer patterns for this population. As shown here, largest group of our study had Medicare fee-for-service insurance. Dual eligibles, people with both Medicare and Medicaid insurance, were second largest, followed by Medicaid. These patterns likely reflect differences in awareness of benefits, referral pathways, and coverage design. Finally, most of hospice claims occurred during the final year of life, aligning with the hospice eligibility requirement of a life expectancy of 6 months or less. Medicaid members tended to receive hospice care the year or two before death for a longer average length of stay than other insurance payers. This observed pattern in Medicaid members may signal the presence of chronic life-limiting conditions, underscoring Medicaid's role in supporting more extended end-of-life care for individuals with complex needs. The claims hospice methodology employed by my team, when linked to death records, provided an accurate understanding of hospice care that aligned with national averages. Variation across health insurance payers suggest differences in access, awareness, and referral patterns. The expansion of eligibility and encouragement of earlier hospice engagement, particularly for individuals with chronic, progressive illnesses, may enhance end-of-life, quality of life, improve equity, and reduce unnecessary interventions near the end of life. So in conclusion, linking CO APCD claims with death records provide a comprehensive and accurate picture of hospice utilization in Colorado. This methodology successfully captured utilization across payers, revealing essential differences in volume and timing of care. Higher utilization among Medicaid and Medicare members may reflect greater familiarity with benefits, targeted advocacy, or differences in referral patterns. These findings provide a foundation for policy and practice changes aimed at providing or improving equity, access, and timing of end of care in Colorado. So here are some of the references which we used for this study. Thank you everyone for joining me today. I would like to take any questions or feedback or suggestions you have for me at this time. You can also reach out to me at mjha@civic.org for any future discussion, or connect with us using one of our social media pages or our email list at www.civic.org. Thank you.